Good evening. On behalf of the Student Academy of Doctors of Audiology, I would like to welcome you to today's Student Practice Management webinar on balancing patient outcomes and profitability. My name is Stephanie Chayesky, and I am pleased to serve as today's course coordinator. I have just a few housekeeping reminders before we begin. First, if you have any technical challenges during the session, please use the chat feature to make me aware, and I will be glad to assist you. Please type your questions into the question queue, and they will be addressed by presenters at the end of today's presentation. And today's presentation is being recorded and will be available for online viewing next week. At this time, it is my pleasure to introduce the course moderator for this session, Kate Witham, the current SATA chair and fourth-year student at Gallaudet University. Kate?
Thank you, Steph. On behalf of the SATA board, I'm excited for the opportunity to welcome AUD students from programs across the country to this session on vestibular management. It is also my distinct pleasure to introduce today's course leader, Dr. Richard Gans. Founder and executive director of the American Institute of Balance, one of the largest balance centers in the US, Dr. Gans received his PhD from the the Ohio State University in auditory vestibular physiology. For over 20 years, has been a leader in the development of vestibular evaluation and rehabilitation techniques, including tests of oscillopsia and postural stability, as well as BPPV treatment. He was presented or published over 150 programs and papers worldwide in the area of equilibrium disorders. He is the author of 8 textbook chapters and texts ranging from diagnostic vestibular testing, vestibular rehabilitation, BPPV treatments, and pediatric vestibular evaluation. Time Medical Publishers will publish his upcoming book, Evaluation and Management of Balance Disorders in Children and Adults. His most current research is in the area of pediatrics, migraine, and psychiatric aspects of dizziness. Dr. Gans served as the president of the American Academy of Audiology 2004 to 2005, and continued to be an active member in professional and government issues. He is an adjunct professor at Nova Southeastern University and the University of South Florida. Take it away, Dr. Richard Gans.
Thank you, Kate, and thank you, Stephanie, for hosting this. I'm glad to meet all of you via online course tonight. Let me just do a little housekeeping before we jump in. I've had the great pleasure since 1998 to have 42 fourth-year residents at AIB. This year we have 4 outstanding students from University of Arkansas, University of Kansas, University of South Florida, and University of Wisconsin. I want to give these 4 students props because right after Labor Day, they will be launching a podcast webinar series devoted to AUD students, all about issues of balance, which they will run and conduct everything themselves. So watch out for that coming sometime after Labor Day. So let's get started. And I'm going to talk about a variety of things today, and let's kind of review what we're going to talk about. And let's see if we can't move this. And I'm stuck. How did I get stuck? Because we were already doing so well. You hear that bouncing? Okay.
I do. Let's just see here if we can, I think I can probably assist. It may be something down in the lower, if you could get to the lower.
I'm going to shut my camera off here. You're still sharing your, there it is. It might have been the webcam that was a problem. So now everything's up again. Okay, we're good. So let's look at what we're going to talk about in the short hour we have together. We're going to look at Well, let me first start by saying this. This year, we had 60 applicants for our 4 fourth-year spots. And I would say that 70%, over 50, well, probably close to 50, of the 70 or 60 or 70 folks that applied all said the same thing, that somebody on their faculty had warned them against getting too involved with vestibular. Oh, you'll pigeonhole yourself. You won't have career opportunities, right? Oh, you can't make money in vestibular. Well, I'm here to tell you that is all complete nonsense. It's just not true. So let's take a look. So we're going to look about equilibrium disorders across the lifespan, the challenges and opportunities. What are some of the best clinical pathways for otologic and non-otologic and non-medical treatment and management? And what is the role of audiology in those? We're going to look at what it takes to implement and develop and successfully manage a vestibular lab, whether you're in private practice or you're within someone else's facility. And then, of course, we'll have time for questions and answers. First of all, we have to agree that equilibrium is what I call a birth to earth phenomenon, right? Meaning that this is something that occurs throughout the lifespan. So audiologists have a unique opportunity to work with all age populations. Let's take a look at them one at a time. Babies. Now, we test babies as young as 3 months of age. If you go to dizzy.com and go to the Dr. Gans blogs, you will see, it's open access, no cost, you will see dozens of video case studies of us working with infants. Now, why would you test a 3-month-old? Well, we know the relationship between sensory neural hearing loss, syndromic mitochondrial disorders, and the audiovestibular expressivity. Also, anyone with delayed milestones. But what about children as they start to go through adolescency? Did you know that the #1 concussed individual in the United States is a female soccer player? And they can obtain what is called a labyrinthine concussion. Now, these rarely create any hearing loss. So it's the audiologist working in vestibular that's going to be able to help in the diagnosis and management of these children. Now, as we move through adolescency, through the childbearing years, what's of critical importance here is, according to the American Academy of Neurology, 1 out of 4 females is a migraine, 1 out of 6 males. This is strongly affected by hormonal changes. So much of the symptoms can be due to the patient's monthly menses cycle. We also know that 25% of all migraineurs will have vertigo or dizziness as a non-headache related aura. But then we move into the post-childbearing years and into what sometimes we refer to as the golden years. BPPV, benign paroxysmal positional vertigo, is the #1 cause of vertigo in all individuals. In fact, it's estimated that by age 70, 50% of all people will get this at least once in their life. But we also have shingles, right, which are due to the herpes simplex virus, secondary to chickenpox when you were a child. The virus lays in the spiral ganglion, and then as you age, it pops out. But what about our older adults? We know that fall risk is a significant problem. Millions of older adults will present at a hospital emergency room dealing with a balance-related fall. In fact, falls are the #1 cause of accidental death in this population. We know that undiagnosed and untreated BPPV can be a leading cause of falls in this population. And that's really sad when you think how easy it is to diagnose and treat this condition. So you make a decision as to who is a potential patient. Well, we're all familiar with many of the otologic conditions that can trigger dizziness, vertigo, or imbalance. Remember, according to Daryl Brackman at the House Ear Institute, the incidence of acoustic neuroma, vestibular schwannoma is only 2 to 4 for 100,000 people. What does that mean? 99,996 individuals who have an MRI are negative for a tumor. But there's also many non-otologic conditions. So as we teach our residents here at the Institute, step away from the ear. If you live by the ear, you'll die by the ear. Now, I know that may sound like sacrilege to an audiologist, but if you only limit yourself to otologic conditions, you are really handcuffing yourself. We have pediatric and adult migraine, head impact, concussion, MTBIs, vestibulotoxicity, chemotherapy, and cisplatin are all vestibulotoxins. And then we have many different comorbidities, particularly diabetes, hypertension. When you go to dizzy.com, you can download all of our textbook chapters and articles. So now as an audiologist, you're thinking to yourself, well, isn't the world wonderful? I'm just going to go out. I was taught that the way I'm going to pay off my student loans is by selling hearing aids. Well, what do we know? Hearing aid sales, while they're very important to everyone's bottom line, you have more people with hooks and line in the water trying to catch these fish. So even though you may have a very important advanced degree in the Doctor of Audiology degree, the reality of it is that the consumer with a hearing loss has many different options to go to. In fact, in the United States, the data actually is that per ear, nose, and throat physician in their own practice, each is responsible for only probably dispensing 8 hearing aids a month per physician. So why do you really want to consider adding vestibular to your practice, or perhaps making it the focus of your practice? Well, one of the things is if you're a one-trick pony and you go lame, you're in trouble. I can tell you there are many smaller private practices that have had to close their doors permanently during COVID. So the more you can diversify your practice, whether it's CIs, vestibular, central auditory processing, tinnitus, the more the better. Okay? The more individuals you have coming into your clinic, the more opportunities you have to offer them services. Now you make a decision. Well, do I need to do every test on every patient? What equipment will I need? What services should I provide? And how am I going to integrate all of this information? There are so many different tests. The reality of it is that if only one test was good, then we would only need one test. But the reality of it is that we need to incorporate many different tests to get a full understanding of what the patient's functional impairments are, and then what is the best management techniques. The idea that vestibular testing is going to be difficult or challenging or uncomfortable is right out of the 1980s. Today's tests are simply not that way. So here's some opportunities. I like to think of this as a crawl, walk, run process. It may be that all you want to do is diagnose and treat BPPV. If that's the case, you might just need a little $5,000 video goggle. If you want to do more, then you can do VNG, Bears, ECOGs, VEMPs. If you want to do even more, you can add rotary chair, video head impulse testing, or some of the more advanced tests. Now, what I'm going to show you financially is think of yourself like your Chick-fil-A, right? People may go there for the sandwich, but what else do they buy? A drink and the waffle fries, right? So if you only sell the chicken sandwich and most of the profit is actually in the soft drinks, guess what? You'll see patients, but your bottom line will not be as good as it could have been because you're not offering the full array of all the components. What about rehabilitation? Should you have physical therapy inside your own four walls? What can you do with vestibular rehabilitation? Well, let's talk about what you can do in your office. First of all, I wrote most of your scope of practice in the vestibular area. Vestibular rehabilitation is in your scope of practice. Just because Medicare doesn't pay you because you're not a physical therapist doesn't mean it's not in your scope of practice. So if you're treating patients, if you will, from the neck up because of BPPV and uncompensated unilateral vestibular dysfunction, you absolutely can do vestibular rehabilitation and you can charge for it. You may have to have the patient sign an ABN, but you certainly can do it. If you're doing self-directed programs, you don't need an ABN because no one pays for self-directed programs. If you think about auditory rehabilitation programs that are supported by take-home exercises, followed up by emails, telephone consults, it's very easy to do. You can also partner with physical therapists, which you're going to need to do, and we recommend strongly. At AIB, because we're an institute, we do everything. So, but we use this mostly for our research and educational aspects. So we don't see knees and hips and backs, right, and ankles. We are only dealing with true vestibular and balance patients. Partnering with physical therapists, they are your colleagues and you need them to work in the full continuum of care with your patients. So if you treat a patient, I'll give you an example. We were just talking with Kate and Stephanie about this before the broadcast. We had a 74-year-old gentleman deafened at 30 months of age due to spinal meningitis. Deaf culture signer. He had BPPV and complaining of his balance. Our Gallaudet trained doctor of audiology, Dr. Faubel, treated the BPPV. Then we walked him across the hall via sign language and got him into his balance retraining program. He was just discharged last week with phenomenal outcomes and success. So an interdisciplinary approach always is the best way to go. Remember, everything should be patient-centered. It's all about the patient. Okay, so how are you going to plan for this? What are you going to do? How much space will I need? What equipment? What kind of people? How do I schedule? How do I learn this? I didn't learn this in school. How do I bill for it? And how do I get physicians to refer to me? Are all those things that you need to know? Absolutely. So let's take a look. So if you are Macy's and you go to the perfume department, what do? They figure out how much the perfume company or the makeup company is going to generate for them per square foot. And you need to think about this with balance space as well. The reality of it is that you don't need a very large space at all. You can do everything you need until you get busy enough where you need a little more space, but you can do everything you need in basically 100 square feet. So in that, you could put a rotary chair with a combined VNG system, your evoked potentials, which will then do ABR, ECOG, VEMP, and then if you want, you can have a VHIT, and you can even use a handheld TIMP reflex decay OAE with a handheld system with Bluetooth. So if you look at the little video you just saw on your right, once the patient is seated in that chair, all of the tests you saw can be completed just in that space. Well, who's going to do this testing? How are you going to schedule it? What is your process going to look like? So very often we do not recommend, once the audiologist gets busy enough, that they necessarily perform all the testing. Remember, audiology students, you're going to make more money with your brains than your hands. If you only try to make money with your hands, you're basically like a cobbler, a shoemaker, or a tailor. You only have two hands. There's only 8 hours in the day. You can only sew on so many buttons. You can only put on so many heels on the shoes. So having support personnel, whether it's fourth year students, technicians, is going to be critically important. What will the patient's journey look like with you? Well, in the first visit, we recommend that you do all of the testing and not have the patient come back for multiple visits to do more testing. If you follow our protocol, you can do all of your testing usually in 90 minutes. Remember, many people misunderstand what needs to be done. If the patient has BPPV, you can bring them back on that second visit and do a cannula repositioning maneuver. Then they come back again, because we always want to validate the efficacy of the treatment. We don't want to guess that we've cleared them. If they need hearing aids, they can come back. We have basically an AIB university. At AIB University, we teach everything you need to know about billing, coding, clinical pathways, scheduling, physician liaison, and clinical and technical training. Let's drill down into some of these. Everybody needs to know about billing and reimbursement, right? Because if you don't get paid, then this is a very expensive hobby. So we recommend that to learn billing and reimbursement, this is nothing magical. There's a family of codes, and every year they're updated. Now, let me show you some good news. So there's a variety of 2020 codes in the fee schedule. What this means is that for a full vestibular patient, without even talking about basic audiology, you're going to generate about $500 per patient. Now, what's exciting for 2021 is that there is now OVEMP, CVEMP, and combined OVEMP and CVEMP codes. The good news is that combined O and CVEMPs is going to reimburse $124. Electrocochleography is moving up from about $74 in 2020 to $115 in 2021. Now, the ABR has gone down a little bit, but still, when you look at our package, it's going to generate about an additional $65. Now, you might be thinking, well, how am I going to get physicians to refer to me? You've got to have the right story. So if you're going to an oncologist, you want to talk about cisplatin and chemotherapy. If you're going to an endocrinologist, you want to talk about diabetes. If you're going to a rheumatologist, you want to talk about osteopenia and osteoporosis. Right? So step away from the ear. Understand that the audio vestibular system, you should be thought of like your heart, your kidneys, your pulmonary system, and stop talking about Meniere's disease and tumors. Not that many people have Meniere's disease and tumors. A lot more people have diabetes, osteopenia, vitamin D deficiencies, and have successfully beat cancer with chemotherapy and cisplatin. So you want to have a game plan in how you talk about these tests with physicians, right? There's been data that shows that 66% of physicians say that unless somebody comes and talks to them and explains things about what you do inside your practice, they're probably not going to send you patients. So you have to understand this is about education, education, education. Physicians simply don't know what they don't know. You also want to have good patient education materials, right? Now, we don't want to talk over their heads. We want to explain things to patients in simple, everyday language, because all they really care about at the end of the day is, I want my life back. Now, if you go to Google and you look at the 160 Google reviews that AIV has, you're going to see one common denominator. I can't believe how nice everybody was. They explained everything to me. It was wonderful. It was like being with family. If testing was fun, this was fun. So that's very, very important that you explain things in ways that are easily understandable. You also want to look at folks in the community that you can partner with, right? Because their scope, whether it's a hospital, a medical clinic, may have more bandwidth than you do. And then also we know that unlike years past, people are not getting information from newspapers. They're getting it from social media. So we want to talk about, let's say November is Diabetes Awareness Month. We want to make sure that patients understand the relationship between diabetes and balance, right? This is an ear, nose, and throat practice we work with. March was Brain Injury Awareness Month, right? Patients may not realize that they also can have a labyrinthine concussion. So we want to expand our opportunities, not implode or restrict them. Here's an audiology practice. This was about, I think it was cardiovascular or hearing and balance. All these kind of things are very important. This is Hampton Roads ENT. So this was about National Diabetes Month and being well. So we want audiology to be linked with wellness, with intervention, with preventative aspects, and not just trying to sell people hearing aids. We also understand that people trust the internet. It's estimated that perhaps as high as 80% of all patients will go to Google or some type of online platform to find out what your Google rating stars are. Are you a 5-star practice or are you a 2-star practice? Do you have 2 Google reviews or do you have 100 Google reviews? So your online virtual reputation is critically important. So we always want to be aware of what is required. And again, how easy is it to find you? Are you accepting the insurances that these people have? They want to know that you're legit. How easy is it for them to find their way to you? Is your website clear? Is it understandable? Is it confusing? Now, Hearing aid revenue needs to be considered. It's estimated that 25 to 30% of people with balance problems have an undiagnosed or untreated bilateral sensory neural hearing loss. And it's not even on their radar screen. They're not going to Audible. They're not going to Slinky Dinky Tone. They're not going online. And 25 to 30% of those, when you make them aware of it and you talk about a continuum of care, will move forward with technology. Now, let's look at the real financials of this. Now, these numbers are all going up in 2021. Audiology codes 92557 actually is going down $3.50. Did you hear what I said? 92557. Comprehensive audiology is going down $3.50. That is more than a 10% drop. Vestibular codes are going up $65 in total. So what does this look like in real dollars and cents for you? Right? So if you were to buy everything, every piece of equipment you need, it's going to cost you about $2,400 a month over 60 months, right? Just like you think about a car or a house or anything. At $600, what that means is you only need 4 patients a month to pay all of your hard costs. So if you start looking at these numbers, right, and you start looking at a combination of the diagnostic revenue combined with the incremental hearing aid sales, because remember, you didn't need to do an open house, you're not advertising, these people are coming through your own clinic, they're coming into your own 4 walls without any increased expense. So if you start looking at that, and by the way, 60 patients is not a lot. At AIB, we see 250 patients a week. 250 patients a week. In the month of July, we had over 100 physicians refer patients to us. That's not 100 patients, that's 100 physicians referring patients to us. I don't think anybody in the hearing aid world has 100 physicians referring patients to them. How do we get 100 physicians to refer to us? We make dizzy patients better. So if you look at the combination of diagnostic testing and the revenue from hearing aids, a solo practitioner just seeing 15 patients a week equals 60 a month. 15 patients a week can basically be seen in 2 days. You can do that in 2 days, 2.5 days if you're slow, but you shouldn't be. You should be able to see 15 patients in 2 days, just one practitioner, or one practitioner with some assistance through a 4th year or technical support. If you then add in that 30% of the 30%, and you look at about $2,500 gross profit per dispensing, you can see that it really starts to add up. So if you are working in an ENT practice where the ENT is already seeing or using ICD-10, R42, dizziness and giddiness 80 times a month, and you test even just 60 of those patients, the combination of the revenue from the diagnostics and incremental hearing aid sales per physician is over $500,000 a year. And again, what do you net from this? The hard costs are the same. So if you don't have an assistant and you're just paying yourself, and we don't add that in, it's well over 360,000. Then you have revenue from hearing aids. So that it's very easy to see that within a private practice, you can do quite well. Now, Kate said that she was doing a externship with one of our dear friends and one of my disciples, Jana Brown. And I'm sure Kate has seen firsthand what both the diagnostics and the incremental hearing aids have done for Jana's practice. And practice is just like that. So that gives you in about a 40-minute dive, a very quick overview of the things that we hope maybe weren't on your radar screen. Maybe you hadn't thought about it. Maybe you heard things that were to the contrary. So our goal in trying to move the profession forward is to move you not away from hearing aids. Hearing aids are going to continue to be an important component of audiology practices for many years. We're not trying to tell anybody not to do hearing aids. That is the last thing that I would tell an audiologist to do. But we would like to, at least, hopefully I'm still on, yes. But what we would like to do is make you aware. I would never tell anybody, don't do hearing aids, just open a balance clinic. That's quite honestly crazy. I wouldn't tell anybody to do that. But certainly, whether you're working with an ENT, in a hospital, in a private practice, begin to look at how vestibular can be an important component in patient care, in community service, and making that transition from being a kind of a retailer with an advanced degree, opposed to being perceived in your community, your medical community, in your civilian community, if you will, as a healer. Because once you transition from the retail model to a healer model, the patient's perception of you changes, the physician's perception of you changes, and it elevates yourself personally, financially, and professionally. So hopefully this information, I know we had to move quite quickly. Sometimes we'll do this over a day, actually. So I'm here. Kate and Stephanie, I'm available to answer all of their brilliant questions. Are you folks there? Did I lose anybody? Uh-oh.
Hey, Dr. Gans.
Yes.
I think Stephanie is trying to get back online. So I will go ahead and I don't have.
I just want to make sure I was still active.
Yeah.
Okay.
I don't have access to all the questions yet. So I will read my own question.
All
So
right.
for a small business startup, so you got a budget and you're not taking over another clinic and you're only one person, do you recommend purchasing all the equipment at once, or kind of as time goes by and you feel you can afford it?
Well, it's a double-edged sword then, because you're giving up a lot of revenue right up front. So there's a lot of ways to finance, right? So you're probably going to do a 60-month lease, which is just another way of financing. Oftentimes groups like Fuel, Elite, Rise ENT will help you finance this.
Oh.
So I would suggest to folks that we've got to look at the demographic. We've got to look at the expenses, right? So one of the things that I've recommended sometimes to folks is if you think when you open your own practice, that doesn't mean that you have to have your own lease or your own building. For example, AIB, I'm inside, one of my clinics is inside a hospital. I pay them rent. It's all my equipment. I make all the money. If I need to move, I simply put the equipment on a truck. I have another one where we're inside a 200 physician multi-specialty group with 4 physician ENTs. I pay no rent. I charge them for the testing, but it's all my equipment and my staff. So there's many, many different ways to do this. This idea that, oh, I've got to go out and I've got to rent 1,200 square feet, or I've got to find a building, is not necessarily the best way to do it, right? You might know of an ophthalmology practice that would be happy to rent you 200 square feet, where you share a waiting room, you have a receptionist already there, you see? So the idea that choking on rent and construction and everything, you are far better off putting the money into equipment that's going to generate revenue for you.
Great. Can you guys hear me now? This is Stephanie.
Hey, Stephanie.
Hey, sorry, somehow my headset muted me and wouldn't unmute me. I do actually have a couple in the queue. The first one is, does your practice do bedside testing such as clinical H and or stepping Fukuda or Romberg? If so, what is their clinical value in your testing?
Great question. Bedside testing or chairside testing can be highly valuable. The Romberg, however, with all due respect, look at the data. Everything we do is evidence-based, right? I've published hundreds of papers and textbook chapters, so everything we do is evidence-based. The Romberg is not sensitive to vestibular. It was developed in the late 1800s to determine tabes dorsalis secondary to neurosyphilis. If you have, and there's no normative data for people over age 60. Now, there are other better aspects. Stepping Fukuda is not that great either. It only has a sensitivity of about 50%. It's all based on loss of tonal, on ipsilateral tonal loss on the side of the involvement, so that the patient will fall or drift to that side. But Herdman has published and other people, it's only got about a 50% test retest value, right? So you can do head impulse testing, but remember head impulse testing, the V-hit is phenomenal, but you have to have a $15,000, $16,000 product, right? So the head impulse test at bedside is among the most sensitive, so long as you're seeing the patient within days of the acute episode. Because there's 2 types of saccades. There's a covert saccade, right, that you can't see, and an overt saccade. The overt saccade you can see within days or maybe up to a week or less of the event. So a lot of the bedside things are, maybe they're okay. Modified CATSIB, the GAN Sensor Organization Performance Test, which is used everywhere. It's a modified CATSIB. Clinical test of sensory integration and balance, foam, eyes open, eyes closed, foam, eyes closed with head shake for higher level. So if you go and download my chapters, you'll see that in several of my chapters, I actually provide you with a table of an analysis of all these bedside tests and their sensitivity and specificity.
Thank you. That's fantastic. The next question comes from someone who would like to know if you have some tips for people who are getting into vestibular practice for doing some outreach with physicians in their area? Like, are there specific ways that they should go about connecting with the physicians?
Absolutely. The first thing is lobotomize your audiology brain. Step away from the ear. What that means is you need to speak to that physician, and here's the other thing. Don't let your ego get in the way. Talk to the nurse, talk to the PA, talk to their medical extender. You don't have to see the physician. What you need to do is get your message across. What we know is if you're going to random new physicians, you may need to have somebody go there 5, 6, 7 times before you start to see referrals. So don't let your ego, oh, I can't believe it, I went and visited, I couldn't talk to anybody, wah. Okay? There's no crying in vestibular audiology, right? You got to toughen up and realize, stop thinking it's all about you. It's not all about you. So if you're going to an endocrinologist, what do you want to talk about? How you can help manage their difficult diabetic patients. So you're going to bring in scientific articles that talk about elevated fall risk relative to diabetics on days when they have high glucose, right? If you're going to a rheumatologist, what are you going to talk about? Psoriatic arthritis, lupus. If you're going to an oncologist, you're going to talk about vestibulotoxicity, bilateral, and why it's so concerning with patients with cisplatin and chemotherapy. If you're going to an OBGYN, why would I go to an OBGYN? Because didn't you just hear in the beginning of our talk, migraine is hormonally triggered? So if a female is a migrainer and she has surgical menopause, a hysterectomy, and she's put on HRT, guess what? HRT can be a leading cause of vertigo. Read. You didn't learn this in school. Unless you went to maybe 3 or 4 schools, nobody's teaching you vestibular. You're learning how to be a technician and how to do a VNG. That's not enough. You've got to become an OBGYN, an internist, a psychiatrist, an endocrinologist, a neuroscientist, an ENT, a physical therapist, to build a good vestibular practice. You've got to understand how to speak to your physician referral sources like a valued colleague. Bring something of value to them. And that would be my advice. Read. It's all there in the scientific literature. Go in with that. Educate the extenders. Educate the PAs. Educate the physician in a non-condescending, collegial, just want to let you know, we have a lot of success with our diabetic patients. For example, the diabetic patient is 3 to 4 times more likely to have BBBV because of decreased blood flow to the inner ear. You see, it's so simple, but you have to read and be a lifelong learner.
Thank you. That's excellent advice. And for this kind of brings me to a question that I had, or that something I wanted to learn more about, which is a good transition. Can you tell us a little bit about the program that you're going to be working on with universities across the country going forward?
Oh, thanks, Stephanie. So as you may know, we are probably one of the largest educators in the world of audiologists, ENTs, neurologists, physical and occupational therapists in the vestibular sciences. So last year we trained over 1,000 folks in the United States and outside as well, Egypt and Jordan, and a lot of other countries. What we're concerned about is that our AUD students are not getting, in our opinion, the majority of programs either don't have the experts to teach you this, they don't have their own clinic where you can physically do this, and they don't have externship sites to send you to where you're really getting mentorship and this kind of education. So what we did was we took our 5-day, 35-hour workshop called Vestibular Assessment and Management, literally bumper to bumper. Every aspect of vestibular assessment and management, we are putting it online and making it available to every AUD student. We're trying to go through the programs, right? But nobody has any, we understand we're not trying to do this to make money. We're trying to support the profession. So this will be available to every AUD student, either through your school's program or to you individually. And it's probably going to be about the price of a good textbook, about $250 for 35 hours. But you have access to Zotero, over 3,000 journal articles. You're going to have quizzes. You'll have everything you need. Video demonstrations, tutorials, and some live interaction with the AIB staff. Samford University in Alabama is our first school. They're coming online with this, I think, August 28th. So you may want to talk to your program directors, your chairs, deans, anybody, but we'll make this available to everyone and anyone. Just to let you know, that same workshop for years at AIB is $1,600.
That is phenomenal. And I can tell you, just from ADA's perspective, we will be glad to help get the word out about that to all of the students that are members of ADA whose programs may not yet have signed on, so that they can at least take advantage of that, because that is just amazing value for students.
Well, what we're also finding is the audiologist that leaves AIB, all of my fourth years have very good job, have multiple job offers 6 months before they graduate. They're all hired at a premium because they know vestibular.
Absolutely. That's an excellent point too. Well, thank you, Dr. Gans. That was so informative, and we are so grateful for your generous donation of your time, your resources for this, and for all of the things that you do for this profession. I'd also like to thank everyone who's here tonight, but if you do have some friends or colleagues that were unable to attend, please let them know that the session has been recorded, and we'll send out a link to attendees after the recording is posted. For more information about future SATA practice management webinars and also Dr. Gans's great program that'll be coming up, you can always go to www.audiologist.org/students. Thanks, everyone. Thanks, Dr. Gans. Have a great evening. Good night.
Thank you all. Thank you for everything you do at ADA, Stephanie and Kate. Great work with your student organization. Much success in the future.
Thank you. Good
Thank
night,
you so
all.
much.